Hello, I'm Jerry Nacarelli. I'm Chief of Cardiology at the Penn State University College of Medicine. And we are at the Heart Rhythm Society meetings here in Denver. And I'm going to present a few minutes on hybrid treatment of atrial fibrillation. Hybrid therapy of atrial fibrillation basically is a combination of therapies. For example, combining drugs and devices, combining drugs and ablation, combining ablation and devices. So given the fact that we have multiple modalities for treating atrial fibrillation, it's very common to mix and match these therapies depending on the patients that you see and the outcomes that they have with the given therapy. Some common hybrid therapies include that we use antiarrhythmic drugs with other drugs. For example, we use antiarrhythmic drugs in combination with upstream therapies, rate control therapies, and anti-embolic therapies. Where typically hybrid therapy is the combination of drugs with devices or drugs with ablation. If we talk about antiarrhythmic therapy in patients with sick sinus syndrome, it's very common that we have to mix this therapy with an atrial-based pacing system in order to have bradycardia support, and we can get a synergistic effect. We also see typically, for example, that antiarrhythmic drugs may organize atrial fibrillation and atrial flutter, and one of the treatments for that is to ablate the flutter, and if the atrial fibrillation is controlled with the drug, that one has a very happy outcome. One of the most common scenarios where we use hybrid therapy is catheter ablation, that if it's not curative and you have a partial efficacy, that we add drugs into this, or we'll talk a little bit about using drugs as part of the ablation protocol. And then finally, there's the possibility of using surgical ablation with drugs, or surgical ablation with catheter ablation, and then with the addition of left atrial occluding devices, this will be another form of hybrid therapy. Now, one of the reasons we need hybrid therapy is that, for example, drugs only work about half the time, and even the most effective drug, amiodarone, works 2/3 of the time. I mentioned that besides anti-embolic and rate control, one set of data that exists is if we add upstream therapy, ACE inhibitors, angiotensin receptor blockers, statins, fish oils, and we add them to a drug like amiodarone, there's prospective data to show that one can get added efficacy. Unfortunately, upstream therapy as monotherapy has not been very encouraging, at least with the large-scale trials that have been published so far. Well, as I mentioned earlier, the predominant form of hybrid therapy is some form of non-pharmacologic therapy with drugs. And we do this every day, for example, in pacemaker patients. We have pacers are implanted predominantly for patients with sick sinus syndrome. Their heart rates are too slow in order to aggressively use antiarrhythmics. And this is probably the most common form of hybrid therapy that's used worldwide. Unfortunately, pacing by itself has been disappointing as monotherapy. There are some algorithms that may suppress some episodes of atrial fibrillation, but there have been multiple trials, including PAC-ATTACK, PA3, and others that have shown essentially disappointing results with pacing as monotherapy for atrial fibrillation. So if there's coexisting sick sinus syndrome, and obviously pacing is a benefit for bradycardia support, and then if there's atrial fibrillation, one could aggressively treat that with antiarrhythmic drugs. Now, another form of hybrid therapy may be what we would call the ablate and pace strategy. That is in patients with rapid atrial fibrillation. One could ablate the AV junction, and then, depending on if the patient's paroxysmal or not, adding antiarrhythmic drugs. Some of the results from the PAVA-CHF trial, though, would suggest that catheter ablation with pulmonary vein isolation may be a better approach, since they showed superior outcomes compared to ablate and pace even with biventricular pacing. I mentioned earlier that a very common form of hybrid therapy is the use of, for example, a class 1C drug to suppress atrial fibrillation in a patient with idiopathic atrial fibrillation. These drugs, by slowing conduction, may convert the atrial fibrillation to atrial flutter. Isthmus ablation for atrial flutter will often restore sinus rhythm, and then one could continue the drug. If we talk about catheter ablation of atrial fibrillation, there are multiple protocols, including pulmonary vein isolation, antral isolation, WACA, ablating electrograms, gangliotic plexi, linear ablation, on and on. In a sense, because there's so many different approaches to catheter ablation of atrial fibrillation, one could argue that there's hybrids of like which approaches is one going to use, and obviously the more aggressive one is, the better the results. Now, we know that the efficacy of drugs is about 50% or so, but the efficacy of even catheter ablations in about the 70% range. Even if one adds drugs, one might push 70 to 80%. And there's at least a 25% or so group that has a repeat ablation. So an increasing market for hybrid therapy is the use of atrial fibrillation therapies of catheter ablation in conjunction with antiarrhythmic drugs. Now, one of the things that goes on is that there have been many centers that use antiarrhythmic drugs and catheter ablation as part of their protocol right out of the box, knowing there's going to be early recurrences, healing after the ablation. There was a study by Turco and all, though, that suggested that the routine addition of drugs compared to just ablation alone, really, there was no improved outcome. So a lot of the addition of drugs in the ablation patients really, I think, has to come to the individual patient. The drug choice is usually based on their presence or absence of structural heart disease, the use of drugs that are safe to use, or maybe drugs that they had partial efficacy outcomes in the past. There is some data for upstream therapies in conjunction with catheter ablation. These have generally been very disappointing. Adding ACEs and ARBs, adding statins to catheter ablation just has not been very effective. And two final forms of hybrid therapy would be the combination, for example, of surgical maze with catheter maze. And there was a presentation here at the Heart Rhythm Society by the University of Virginia showing that in patients who were refractory to one previous catheter ablation or drug therapy, that by doing a surgical ablation first and cleaning up by doing catheter ablation, actually saved a lot of operator time and had better outcomes than just doing a repeat catheter ablation. So that may be a interesting paradigm for some refractory patients. Finally, I mentioned that investigationally there are left atrial appendage occluding devices for obliterating the left atrial appendage to minimize stroke. One could foresee in the future that following a catheter ablation, these devices may be put on in either the same sitting or in a follow-up sitting. So some final thoughts on hybrid therapy of atrial fibrillation. Hybrid therapy of atrial fibrillation is common. We do it all the time. We just don't talk about it very much. Pacing is predominantly limited to bradycardia supporting sick sinus syndromes, so more aggressive pharmacologic and ablative therapies can be undertaken. Antiarrhythmic drugs are commonly used in patients post-ablation. We really could use more data to know which drugs and when and whether it's a good idea or not. We may see some combination of catheter and surgical hybrid therapies. Probably more commonly what we're seeing now is surgical mini-maze procedures with partial efficacy, either cleaned up by a catheter ablation afterwards or some drugs. I think the addition of left atrial occluding devices to the above options will occur in the future. Thank you very much.